Examination findings: Hypertrophic cardiomyopathy. Starting peripherally to centrally, the patient's rhythm may be in atrial fibrillation. This is important to note as the prominent A wave of the JVP, the double apical impulse, and the fourth heart sound may not be present if the patient is in AF. These signs are usually present when the patient is in sinus rhythm. The pulse itself may have a jerky character with a double carotid impulse. As mentioned before, there may be prominent A waves of the JVP due to reduced right ventricular compliance. The apex beat may be minimally displaced or displaced in advanced stages of the disease. As mentioned before, a double or even a triple impulse may be felt. A fourth heart sound may be present. A parasternal thrill may be present, which represents turbulent flow in the left ventricular outflow tract. An apical thrill may also be present, which can represent mitral regurgitation due to the systolic anterior motion of the mitral valve. In severe cases, reversed splitting of the second heart sound may be audible. There are two murmurs characteristic of hypertrophic obstructive cardiomyopathy. The left ventricular outflow obstruction typically causes an ejection crescendo-decrescendo murmur. This occurs after the first heart sound or in mid-systole. This murmur is best heard in the left sternal edge and apex. The murmur radiates to the sternal border and the suprasternal notch, but does not radiate to the carotids or the neck. Maneuvers, such as the Valsalva maneuver, will increase the murmur. Standing will also increase the murmur. Holding a hand grip and squatting will diminish the murmur. The second murmur that may be heard is a pansystolic murmur of mitral regurgitation, which reflects systolic anterior motion of the mitral valve. This murmur is best heard in the apex and radiates to the axilla. It is important to look for signs of heart failure, as hypertrophic cardiomyopathy is often associated with diastolic dysfunction due to a stiff, non-compliant ventricle.